Hey, so one of the exemplars for my students is COPD this summer. And so I want to just break that down, talking about pink puffers and blue bloaters, and hopefully give a really well-rounded and a little more extensive um, information for the student nurse or new nurses or nurses that just want to refresh, um, know about this respiratory disorder, COPD. It's chronic obstructive pulmonary disease or disorder. Let's get started. Okay, so at the beginning of this, of course, we've got objectives. I've got, it talks about altered gas exchange in here. And the reason why I'm pointing that out is because our concept, because we have a concept-based curriculum, is gas exchange. And this is where we're seeing these respiratory issues, and especially COPD, it is a gas exchange issue. And it'll finish up. I'll let you read them. They're there. We do have chest tubes down here, and I'm just going to say that my students next week will be doing a lab on chest tubes. So I have included this. So somewhere down the line, there will be slides a little bit and talk a little bit about chest tubes. Maybe not on this specific, but I've got several other videos coming. So keep looking. Acute bronchitis. And the reason why I have this slide here today is because there's two bronchitis. There's an acute and a chronic. COPD is caused by a chronic bronchitis or emphysema, but acute bronchitis is an extension of upper respiratory infection, usually viral. It's usually has symptoms of the common cold in the beginning, but we can do bronchodilators, cough medicines, humidification, warm or cool, whichever is preferred. Also, I wanted to point this out because we do damage to our lungs, and we're not sometimes aware, or we don't understand this. But occupational lung disorders can happen. Coal dust with coal mines, we heard of black lung. Hemp, flax, cotton processing plants, any kind of plant that has fibers that are in the air that we inhale, or anything with chemicals. Also, asbestos is down here, and it can cause a rare cancer of the chest lining, mesothelioma. So if you're around asbestos or you know of anybody, that needs to be looked into immediately, and those people need to get away from that. As we go on with the slides, I also talk about like firefighters that inhale smoke and different things like that. So we can cause the damage based on different things out there that can cause us to have COPD. There's different things that happen, but the main kind of base thing is we have problems getting air in and getting air out. And that's what we see with chronic bronchitis, asthma, emphysema, and atelectasis. Now, chronic bronchitis and emphysema are the causes or the etiology or disorders that support COPD. That's how we have COPD. But asthma is also another obstructive pulmonary disorder, but it can be resolved. If you have an exacerbation and you're having a problem with asthma, it can be resolved. But COPD, it's irreversible. We can reverse asthma, we can fix what's going on, and they can go back to their normal. But for COPD, that does not happen. Chronic obstructive pulmonary disease, like I said, emphysema and chronic bronchitis are the causes, the diagnosis that we get. They're different. They're going to present differently, and we're going to break those down, but they still have COPD. Treatment, we can give bronchodilators and anti-inflammatory agents. Smoking cessation. The number one cause for COPD is smoking. And so we really want to encourage smoking cessation. What we need to do is get the doctor to prescribe a nicotine patch so that we can put that on them so they don't go through withdrawal from nicotine. We need to encourage family and friends, anybody that lives in the household or drives them around or anything, not to smoke around them, or to quit smoking also, because they're going to smell it on their clothes. They're going to smell it when they come in, and it's going to make them want to smoke again, that craving, because it's a habit. It's an addiction. There's respiratory rehab programs out there, nutrition, we're going to talk about that, complementary and alternative therapies that are out there. COPD. So like I said, it is a problem where air coming in and coming out is the issue. So we're just having, and it's under the concept of gas exchange, because what's happening is we're not having gas exchange. We're not able. So chronic air trapping and lung hyperinflation is what we see. So we've got air trapping going on. We can't get the air out. It's irreversible damage. Number one cause I said was smoking. We said that, but we also have other things. It's that outside irritants exposure can cause COPD. And so we see people that are in these during 9/11, you know, when everybody was there inhaling all that from the towers, caused a lot of cancers. They inhaled a lot of different chemicals and stuff from that. And that became a problem. They have a decreased SaO2, which is an oxygen saturation. It's what when we put our little probe on and we look up at the monitor, that is the saturation that we see. Normally we think 95 to 100, 94 to 100 is what we want, depending on your book. But that's good, right? That's a great oxygen saturation. Well, for people that have damaged lungs, that have issues going on where they have air trapping and where they're having gas exchange issues due to an obstructive issue, a normal SAT for them will be 88 to 93%. Write that in your notes. And the thing of it is we don't want to put more oxygen on them to try to get that oxygen saturation up. They should have between 2 to 3 liters. I wouldn't go up to 4. I wouldn't do anything above 3 liters. You need a doctor's order. What happens is if we increase the oxygen, it will decrease their drive to breathe, and they will stop breathing. They'll go into respiratory failure and respiratory arrest. And the reason what happens is as we decrease that drive to breathe, their CO2 level is going to continue to increase, causing them to become more or even more severely acidotic. And so we don't need to do that. They will have clubbing of fingers due to severe hypoxemia. We can see that, and I do have a picture of that. If you've never seen it, it's a spoon-like shape, kind of round, bulbous looking into the finger. The nail curves over. That is clubbing. So when you see that, you know that these patients have had perfusion, severe hypoxemia. There's some problem going on that they're not getting the oxygen that they need. Complications of COPD. Cor pulmonale is one, and we'll go into depth with this one. It's right-sided heart failure, acute respiratory failure, peptic ulcer and GERD, which is gastroesophageal reflux disease, and spontaneous pneumothoraxis. So we can have a pneumo, which is where the air, there's pressure and it drops the lung, and that's where they need a chest tube and things like that to help re-expand the lung. Cor pulmonale, question mark. What is it, right? Well, I love this. It's an abnormal enlargement of the right side of the heart as a result of disease of the lungs. What's happening is we're causing pulmonary hypertension in the lungs. The right side of the heart is trying to pump the blood into hard fibrotic lungs, and this leads to pulmonary hypertension. So that pressure in the arteries in the lungs become higher, and they have pulmonary hypertension. Cor pulmonale is a serious heart condition. It's right-sided heart failure. It develops with advanced lung disease. There's no treatment, and I know that it says can there, and I apologize. It should say they can't reverse it. They can't. Once we're there, it's severe. The right-sided failure is there. We can't fix that, but we can prevent it, hopefully, from happening. And we also can hopefully avoid smoking, pollution, anything inhaling that would damage the lungs even more, and have the patient really manage their lung disease. This is right-sided heart failure. Cor pulmonale and COPDers can have it, especially towards if they're severe. It occurs when low oxygen levels due to COPD cause a rise in the blood pressure in the arteries in the lungs, like I said, and this causes the pulmonary hypertension. So when we have this happening, we have an increase in pressure and places excess strain on the heart's right ventricle. And if you work a muscle out, if you overwork the heart muscle where it's trying to pump, that's why hypertension can cause left-sided failure. So if you keep on trying, what happens is it eventually gets a thicker, kind of flabby. It's not an effective muscle. What we're given is a very effective muscle, and we need to take care of it. And so what happens is it's trying, it'll become thick and larger, and it's just not going to pump. The mechanical part of the heart on the right-sided ventricle is not going to work like it should. And because of that, it's just not going to do what it needs to do to help us perfuse. Okay, so let's break it down. We have pink puffers. That's our emphysema patients. They're going to present differently and they're going to look differently completely. They're going to look different on paper, in person, all that compared to our chronic bronchitis or our blue bloaters. Our pink puffers, remember, are emphysema. They're pink in skin because they are perfusing. They have oxygen. In the beginning of emphysema, everything looks kind of normal. Our blood gases can look kind of normal. We've got oxygen going on. Our CO2 can be within norm. We're not having those issues. But what happens is the alveoli in the lung, if you go back and review your chapter or review whatever, the whole respiratory system, the alveoli is where that gas exchange takes place. It's kind of bulbous looking. And what happens is that it's been damaged. It loses its elasticity. We have a decrease in elasticity. We have a decrease in surfactant. So everything's not, it's kind of hardened. It's not doing what it needs to do where the gas exchange can take place. Because of that, our bodies are going, we need to breathe. We've got to get this air out. It's air trapping. And so we'll start to huff and puff. We're going to blow. As you can see, we're going to go, right? Because we're trying to blow off the CO2. We're trying to get rid of the air that's wanting to trap. They're barrel chested because when we're an emphysema patient, we're using every muscle and every part of what we've got within to try to breathe effectively so that we can have an effective gas exchange. Because we're not having that is why our body's doing this. It's like we've got to fix this. We've got to maintain homeostasis. We've got to maintain life. There's usually not a chronic cough, but they can have a cough usually in the morning when they wake up. They can cough, and it's not like the chronic bronchitis patient. So you're not going to see it as much. It's not a chronic cough, but they can cough here and there. They'll go into tripod positioning. If they lean forward, it's going to help drop that diaphragm, expand that the lungs so that they have more effective breathing. They're trying to breathe. It's a more comfortable place. If you've ever laid flat on your back, it's hard to breathe. You really struggle, especially if you're struggling, and especially people that are overweight, things like that. It's just like putting something up there. But if we lean forward, everything goes forward, and that can help us breathe. Tripod positioning. Hyperresonance when percussing the lungs. Well, if anytime we're percussing, if it's fluid, it's going to be a dull sound. If it's air, it's going to be a drum sound, a drum-like sound. So because we're air trapping, there's a lot of air. We have a hyperinflation of the lungs. Because of that, when we percuss, it's going to have a hyperresonance. We're going to hear it. Pink because they are perfused, they are in respiratory acidosis, but it's normally towards the end or more severe part of emphysema. In the beginning, they're perfusing, they're not they don't have hypoxia, they're actually still able to have somewhat of a gas exchange and things are okay. But as they progress, it worsens. So they can't get the CO2 out, and that's where they'll start to go into respiratory acidosis. They're holding on to CO2. The damaged alveoli loses its elasticity, causing that air trapping, like I said. This is a little cute dragon. There's some things down there. Once we get to a certain point, as you see at the bottom, it says can lead to right-sided heart failure. It can. We see it more with chronic bronchitis than the emphysema. But in the end, when we have pulmonary hypertension, we can have these issues. But we see it more with the blue bloater than we do the pink puffer. But when we get to the end stage of COPD, emphysema, pink puffer, or blue bloater, chronic bronchitis, we can go into heart failure. We see it more on one side than the other, but both can present. We can have an ineffective cough. You can just go down through all those and then and read through. They're thin in appearance. They use all their muscles to breathe. They're really trying, and they get that barrel-chested look. Pursed lip breathing. This is something that you want them to do because we want to extend our exhalation. So by doing that, we inhale through the nose with 2 seconds and exhale with pursed lips for 4. So it's, and you want to demonstrate for your patient and have them demonstrate back that they know. It's like blowing a kiss. This prevents air trapping and air collapse. So we really need them to do that. It's going to extend that exhalation. These are some alternative therapies. Ginger and cinnamon for aromatic digestives that provide benefit for emphysema patients. And very small doses of chili are useful for mucolytic agents. The ginger and cinnamon will help with the stomach. They can have issues with GERD. There are over-the-counters, and also physicians can prescribe medicines to help prevent that. Here's our blue bloater, chronic bronchitis. You're going to have, it breaks it down there. They're dusky because they're cyanotic. They're going to have an increase in hemoglobin. And the reason why is because they're severe hypoxic. They have hypoxia severe. They're also hypercapnic, meaning they have a high CO2 level. And because of this, the body's like, we need more red blood cells. We need more cells to carry oxygen around. So they're going to produce more red blood cells, causing an increase in your hemoglobin. You're going to have an increased respiratory rate, of course, and they can have clubbing. This is where we see the right-sided failure. And we're going to see edema and increased JVD, which jugular vascular distension. And that's because we are fluid overloaded due to right-sided heart failure for cor pulmonale. It can be they're going to have that cardiac enlargement. That's the right-sided heart failure. What happens is we've overused the muscle. Your heart's like this, and it's going to pump, pump, pump. When we overuse a muscle by pushing against, or however, usually blood pressure, one side or the other, if it's in the lungs, it's pulmonary hypertension, and it's going to cause the right ventricle to be used to where it can't be used anymore. And it becomes kind of flabby, and it's just not going to do the pump that it needs to do. So what happens is it starts to fail, and then we have fluids that back up into the lungs, and we go into fluid overload. Blue bloater chronic bronchitis patients are fluid overload patients. So we can see that, and that's what causes this increase in JVD, and we'll have edema. So always they're blue because they're cyanotic, severe hypoxemia, and also I always think blue like water. They're full of it, right? Okay. There's your cyanosis or cyanotic. Usually the client is obese. And on the flip side, the pink puffer is thin, skinny, and barrel-chested. They have chronic cough and sputum. They're going to be ones that sound like washing machines. They're like, right? We have crackles and wheezes. And when you need to be concerned is when you have a decrease. They've been doing this, and then all of a sudden you don't hear it. That means everything's solidifying. It means they're going to go into respiratory failure and arrest. Edema due to the cor pulmonale, which is the right-sided heart failure. Inflammation of the bronchi, so we can give stuff to help with inflammation. Usually steroids are given, and things to help with excessive mucus production. We want to give medicines for that, but they'll have excessive mucus production with this. They're just everything. On the flip side, they're a little more dry. They're pink. They're puffing. They're using everything. They look like they've stressed themselves. They do tripod positioning with pink puffers. These folks are just not doing well at all, either side. But blue bloaters are more fluid overloaded, right-sided heart failure, or cor pulmonale. They're going to have a lot of mucus, wheezing, crackles. We're listening to all that good stuff. They're more obese, and on the pink puffer side are more thin. So our lab values, of course, we're going to have the increase in red blood cells. That's compensating for the hypoxia. I've already talked about that twice. ABGs, you're going to have a low pH and a high CO2. So we're going to be in respiratory acidosis. We're going to see it immediately with our chronic bronchitis, but we will see it eventually with our emphysema patients. They're low PaO2. If it's less than 80, they have hypoxemia. And that's what we see. They're restless, decreased LOC, and confusion are the first signs that we see when patients are not doing well, when they are making a turn with COPD. Respiratory failure is where we're going. They have an increase in CO2. We need to use BiPAP. So we don't want to give drugs, guys. You don't want to just throw drugs or medicines at them. It's not going to fix it. Just by offloading fluid off of a blue bloater is not going to fix the problem. The CO2 has had them go into a respiratory acidosis. They're severe hypoxic and severe hypercapnic. And that's our blue bloaters. On the other side, our emphysema patients, they're usually normal in their ABGs, and as they worsen, though, they'll become acidotic. They're maintaining or holding on to CO2. We have to mechanically remove the CO2 by doing BiPAP or intubation. We prefer BiPAP first. Put BiPAP on them, that's bi-level positive airway pressure, and try to blow the CO2 off. It's going to push air in and help them blow it off. It'll help with the inspiration and expiration. And by doing that, we're hopefully going to reverse that severe acidosis. Drugs can help. We do give drugs also. We'll give bronchodilator stuff, but the first choice will be to try to blow the CO2 off to help with ventilation. So BiPAP, first choice. We don't ever want to give opioids, no benzoids. Let's not suppress respirations with anything. We need these patients or clients to breathe. They've got to. They're already struggling. If you suppress respiration or depress respirations due to a medication that's given, you're only going to make them hold on to carbon dioxide more because they're not breathing. The way to get rid of CO2 is to blow it off. That's why to become respiratory alkalotic, we're huffing and puffing it out. We're blowing it out. Those are the people that are anxious. Those are the people that are having panic attacks and they're breathing very quickly. When that happens, they're tachypnic and they blow off all their CO2. So we need to slow them down and we need to have them take deep breaths. But for this situation, we don't need to suppress respirations at all. We need them to effectively breathe. It's an obstructive disorder. They can do cool mist at night, humidify the air. Make sure if they do that, that they use distilled water. We don't need germs flying through that they're inhaling from the water, local water. We also want to make sure that they change that water out, usually after each use, but at least within 24 hours. Before bed, mobilize their secretions. They can take Mucinex or any other product that will help mobilize, medication that will help mobilize those secretions, because we need to get them moving. We don't want them to solidify because then we'll go into pneumonias and all that good stuff that can cause a lot more issue. Teaching. They're going to be fatigued and short of breath. They need to know it. That's normal. They're going to have a dry mouth because they're mouth breathing, a lot of them. Oral hygiene before meals will help with that. They need to do more frequent oral hygiene. We need to do it for them if they're in the hospitals. This also will help with taste. They don't want to eat, but they need to because there is a much higher caloric demand if you're in respiratory distress. These patients are, COPDers are, they need all that energy to breathe. They're using everything they have. So they need energy, and to get it is through food. And we need small, frequent meals, around 6 meals or more with high calories and protein in the day to help this. You don't need to stuff themselves with 3 meals. That will just make them bloated. They're not going to get what they need, and it's going to cause problems. No exercise 1 hour before eating or after. They should lie down and rest before meals and after meals to allow themselves to rebound after eating, because it takes a lot of oxygen and energy when they're eating. If they feel like they can't breathe when they're eating because they're having to chew, they can use oxygen if they've been prescribed it. Put their oxygen on. Avoid gassy foods. It's just going to make them bloated and push on the diaphragm, which makes them work harder to breathe. So no carbonated drinks, no beans, no anything that causes gas. Broccoli about kills me, and onions. So there you go. There's 2. Increase fluids, drink, 8 ounces, 8 glasses, 8 ounces or more a day to help thin the secretions. And that's with anything. If you've got thick secretions, I don't care what you have, flu, COVID, um, you know, uh, RSV, whatever it is, whatever where you have a lot of secretions, excuse me, bronchitis, then go ahead and drink more fluid. Increased fluids will thin secretions. And then call the doctor if you have increased sputum, if you have a fever, or you have worsening dyspnea, difficult, your breathing's becoming even more difficult. If that's the case, call the doctor because something's going on and they need to intervene or things will get worse. Vaccines, we need to talk to our patients about it, guys. I know it's been a political thing about COVID, but we are talking about pneumococcal, which is pneumonia. You get it every 5 years, and influenza flu every year. Giving these vaccines will help prevent them, hopefully, from getting these, and these can be very detrimental, pneumonia and flu. And in the future, guys, we'll be talking about COVID with them because they're at a high risk. It's going to be detrimental to them if we're not careful. Here is a question. Go ahead and read. An initial admission assessment of a patient with acute exacerbation of chronic obstructive pulmonary disease or COPD. The nurse is likely to expect which signs and symptoms? Tensing of muscle, shoulder muscles, inability to tolerate sitting up. No, they need to sit up. Flaring of nostrils, complete sentences with no effort, or sternal retraction. Tensing of shoulder muscles. When you're taking a breath, if you're really trying to breathe, you're going to see this movement, aren't you? They're using what they need. They're tensing. If they're in an acute exacerbation, that means they're struggling. Inability to tolerate sitting up. No, they're going to want to sit up. They're going to want a tripod. They need to drop everything. They're trying to breathe, and it's natural for us to want to sit up. So don't lay your patient flat. Get them up. They need to breathe. Flaring of nostrils. We're going to see this with kids a lot. If you see infants, toddlers, small children, they flare. You can really see it, but you see it with adults too. Flaring of nostrils is the body's way of trying to get more air in. It's doing everything in its power. It says, we're not getting oxygen, we're not getting air. Now I'm going to flare. Complete sentences with no effort. No. If you have emphysema, you do small, jerky little sentences. If you can't breathe, you're not going to be going into long sentence structures, are you? No, you're going to be yes, no, whatever you have to do to communicate with little. Sternal retractions. The sternum actually goes towards the backbone. We see this with infants and small children. We can also see it with adults too and elderly. Whenever we see it more with the younger people though, I think personally, I might be wrong, I'm not a pulmonologist, but sternal retractions, they're breathing with everything they have and the sternum is going all the way. They're trying to squeeze the air when they take the breath in. When they take the breath in, it goes out. When they blow out, and I mean they're using every bit of muscle and it just goes in and out like this. It's definitely something you will never forget when you see it. And last but not least is this slide, and I love it. It's a great one to look at when you're making your list. For my students, they need to go through the chapter, the pages I've assigned, and read through. If they don't know a word, if they don't know what we're talking, if that I'm talking about, or the books, written about, look it up because this is the medical terminology. But the pink puffer will be thin in appearance. They'll have an increased CO2 retention. Now, they both have CO2 retentions, and I want to make it a point to say that. But the chronic bronchitis blue bloaters, they are hypercapnic. That means their CO2 is high. They are severe respiratory acidosis. An emphysema patient or person is not. They normally have normal ABGs in the beginning and they'll start to worsen and they'll get a high, and then they'll start to retain, but they will eventually go into respiratory acidosis. They have pursed lip breathing. All of them are good. You'll see digital clubbing, cardiac enlargement. That's with our blue bloaters. But in the end, they're all struggling. It's a COPD across the board, but they do present differently, pink puffers and blue bloaters. So please make sure that you go through, read anything. If you're not familiar with medications that are given, look in your book for those. There's a great chart in the book that we have that breaks down emphysema, chronic bronchitis, and asthma. So take a look at that, and I think you'll do great. I hope this helps. Thank you.